Does taking a GLP-1 medication make you exercise less? Well, an interesting study presented at the Endocrine Society's annual meeting suggests it might. And I think we really need to talk about that, but not just for GLP-1s. We actually need to talk about it as it relates to all medications, whether it's statins or antipsychotics and many others. So first, let's talk about the study. And remember, first, this was presented at a conference, not published in a peer-reviewed journal, so some details may change. But as it was presented, a retrospective review found that adults taking GLP-1 medications, semaglutide, liraglutide, tirzepatide, they significantly reduced their physical activity after starting treatment. So for example, daily steps dropped from an average of 5,047 to 4,487, and moderate to vigorous physical activity fell from 28 minutes to 22 minutes per day. So here's the obvious question, right? Why would someone who's losing weight on a powerful medication become less physically active? No physician tells their patients to exercise less, right? That's not the conversation happening, but the problem may be that there is no conversation happening about exercise, and that's what we have to fix. So medicine has a tendency to treat the prescription as the intervention, right? Once the medication is started, the visit kind of moves on. Lifestyle may get a brief mention or an offhand comment, but the patient often leaves without a clear, specific, actionable plan for staying physically active alongside the medication. And that's not on purpose. It's just part of the system and the status quo, time constraints, physician knowledge, and it may be contributing to a pattern that undermines the very outcomes we're trying to achieve. And as I mentioned, this isn't unique to GLP-1. So take statins, for example. Many people experience this sort of health halo effect after starting a statin or other cholesterol-lowering medication. They sort of unconsciously, I guess you can say, they relax their dietary habits and their physical activities. The reasoning often, even if subconscious, is that the drug is taking care of it, right? I don't need to be as careful. The other part is that statin muscle effects can complicate this, right? They're real. Myalgias, even mild ones, can reduce motivation and ability to exercise. So they're not the real serious muscle side effects, but they're enough to limit your activities. Patients feel less energetic, they sit more, they move less, and the medications that was, I guess you'd say, supposed to reduce cardiovascular risk may be partially undoing its own benefit by promoting a more sedentary lifestyle. But do we screen for that? Do we advise patients how to handle it or provide support and solutions? No, not really, not very often at all. And what about antipsychotic medications, which I mentioned before, where patients can routinely gain 30, 40, up to 70 pounds, as our own Hannah Warren has documented in her experience? What kind of support is given for that? Again, not much, if any. So GLP-1 medications may be creating this dynamic at a scale we've never seen before. These are now among the most prescribed medications in the world, and the implications of a population-wide reduction in physical activity among the GLP-1 users is very significant. Because remember, these medications don't selectively reduce fat, they reduce body weight, including fat and lean muscle. And that could have real consequences for long-term metabolic health, for our functional capacity, bone density, and cardiovascular risk. Now, protein intake and physical activity, specifically some form of resistance training, are the primary clinical tools we have for preserving muscle mass during weight loss. When GLP-1 medications reduce physical activity at the same time they're causing muscle loss, those two effects compound each other in a very meaningful way. And you could say biology is actively working against us here, right? GLP-1 medications can cause significant side effects like fatigue and nausea and GI symptoms, particularly in the early weeks of treatment. And these symptoms can combine to reduce energy and motivation to exercise. This isn't just quote unquote being lazy, right? It's the pharmacology of the drug working against you. And on top of that, our biology kind of further compounds this because when we face rapid caloric restriction, we have a survival response where the brain downregulates our non-exercise activity thermogenesis, or NEAT, N-E-A-T, and that further reduces our activity. Okay, so given all this, kind of this 1-2 punch that decreases physical activity, let's discuss what that clinical response should look like. First, the exercise conversation needs to happen at the time of the prescription, not as an afterthought, not as a try to stay active, but as a specific, personalized, structured recommendation. What type of exercise? How often? How much resistance training? What is realistic given this patient's current mobility, their joint pain, their fitness level? Because remember, the study found that the largest activity declines were in people with pre-existing joint pain or muscle pain or physical limitations. Those are the patients who need the most specific guidance and not just generic encouragement to move more. They need support. They might need physical therapy, personal trainers, whatever support they can access. Again, not just a handout and a good luck as they go out the door. Second, physical activity needs to be assessed at every follow-up visit, not occasionally, not once a year, every visit. Are you getting resistance training? How much? How often? Has your daily movement changed since starting the medication? Are the side effects affecting your ability to exercise or your desire to exercise? These are clinical questions that deserve clinical attention at every visit and even between visits if possible. Third, I want to raise a question that I think deserves serious consideration. Should some form of activity monitor be prescribed alongside GLP-1 medications? Patients who track their activity tend to be more aware of their patterns and more responsive when those patterns change in the wrong direction. Remember the old saying, what gets measured gets managed, right? If we truly prioritize lifestyle and true metabolic health as much as we do drug prescriptions, it wouldn't seem so crazy to suggest insurance coverage for activity monitors or physical therapy or personal trainers, exercise classes, or whatever it takes to get our patients moving and building their muscle mass. The broader point here extends beyond GLP-1s, right? Medicine has developed a tendency to treat the prescription as the complete intervention. We write the script, we hand it over, and we move on to the next patient. The lifestyle conversation gets compressed into the margins of a busy clinical visit. GLP-1 medications are genuinely powerful tools that are helping many patients achieve meaningful weight loss and at least short-term metabolic improvements. But a drug that reduces appetite, promotes muscle loss to a degree, and now even appears to reduce physical activity in many users, that drug is not delivering its full potential, at least not without a structured, proactive, personalized exercise plan alongside it. So what do you think? Should medicine as a whole emphasize exercise prescriptions and support as much as we do medications? Let me know your thoughts and let me know what you think it would take to actually make this a reality. And if this was helpful, please like and subscribe. And even better, if you have an idea of people we can interview, experts on this topic, please let us know. So thank you for watching. I'm Dr. Bret Scher, and we will see you here next time at Metabolic Mind, a nonprofit initiative of Bazooki Group.